Hi guys, welcome to today's session. Today we are here to talk to you about the management protocol of the blunt abdominal trauma. So let me just see if it all your life and then we'll be talking about it. Right. So welcome guys. Today we are here to talk to you about the management protocol of the blunt abdominal trauma. Uh, yeah. If I'm audible and visible to you, please give me a thumbs up. Okay, great. Okay, so let's start. Let's start by talking about the management protocol for the blunt abdominal trauma. Now, let us begin with the clinical case scenario. Okay, so let's kind of begin with the clinical case scenario over here. So, what is the clinical case scenario which we have? There is a patient who is suffering from a road traffic accident, and the patient has been brought to the hospital. The vitals of the patient are given to you. Let's say the vitals, like the BP is, let's say, 110 millimeters of mercury, pulse is, let's say, 90 per minute, and abdominal examination you get signs of peritonitis. What is the next step in the management of this particular patient? So can you please tell me guys, the options which you have are fast, FAST, DPL, that is a diagnostic peritoneal lavage. You can go in for a CCT and exploratory laparotomy. So can you please tell me guys, what is the diagnosis of this particular patient, like what is the next step in the management of this particular patient? Now if you say that the next step in the management of this particular patient is fast, you would be wrong. If you say that it is a diagnostic peritoneal lavage, again, that's not going to be the answer. The correct answer over here is an exploratory laparotomy. Now, I'm sure that you must have got this particular answer, but if not, let's kind of walk you through over it. Now, okay, so what did I tell you? The answer is exploratory laparotomy. Let me just go and revisit this particular case. There's a patient with a road traffic accident brought to the hospital. The vitals are 110 millimeters of mercury, like the BP is 110 millimeters of mercury, pulse is, let's say, 90 per minute. On abdominal examination, there's the signs of peritonitis. The next step is exploratory laparotomy. Now, let me just walk you through it and let me just explain it to you why this is the answer. But before we go into any details of this particular topic, let us discuss FAST in detail. Okay, so what does FAST stands for? FAST basically stands for Focused Assessment Sonogram for Trauma. Okay, what is FAST? FAST is Focused Assessment Sonogram for Trauma. Now, okay, now let's talk about this. What is an aim of this? Okay, so whenever we do anything in our life, we should always have an aim. So what is the aim of performing a fast? The basic aim of performing a fast is we want to look for an intraperitoneal fluid collection. Okay, what do you want to look for? You want to look for an intraperitoneal fluid collection. This is what you want to look for. Now, what do you do in the fast? Okay, so fast is nothing. It is basically a USG, which you're basically doing in the emergency room. Okay, so if at all you perform a USG in the emergency room, this is what is called as a fast. Now, how do you perform it? So you basically take a USG probe and you keep it at 4 positions. What are these 4 positions? Where do you keep it? So you keep it in the epigastric region, in the right hypochondrium, in the left hypochondrium, and in the pelvic region. So you keep that particular USG probe at 4 positions. That is your right hypochondrium, epigastric region, right hypochondrium, left hypochondrium, and the pelvic. Now, when you keep this USG probe in the epigastric region, what are you looking for? You're looking for any fluid in the pericardial space. So you basically are looking for a pericardial fluid collection. Then when you keep this particular probe in the right hypochondrium, you're basically looking for the fluid around the liver. In basically the left hypochondrium, you're basically looking for the fluid around the spleen and the pelvic region, because that is the most dependent area. Whatever the fluid, it can get deposited in the pelvic, and that is why that is the 4th position which you're looking for. Now, what is the amount of fluid which can be detected by the fast? 100 ml. Okay, so Lovin Willy basically mentions 50 ml, but if you take into consideration all the reliable sources, the answer is 100 ml. So if you have 100 ml in the option, you can go for that. So okay, so let's kind of recollect what we have done till now. What is FAST? FAST is Focused Assessment Sonogram for Trauma. Your options might contain it is focused abdominal. No, it is not. Now, it is basically used to detect the intraperitoneal fluid collection. Now, why do you want to detect an intraperitoneal fluid collection? Now, normally you and me, we don't have a lot of intraperitoneal fluid. But let's say there is a patient of a trauma who is being brought to the hospital. In the hospital, let's say the patient is having around 50 or 100 ml of the intraperitoneal fluid collection. Okay, it basically tells you that there is some or the other organ injury. So let's say there is an injury to the intestine, let's say there is an injury to a vessel or something like that. So it is trying to tell you that, you know what, there is some or the other intra-abdominal injury which is present in this particular patient, and that is a kind of a red flag, and you have to evaluate this particular patient in a proper manner. Okay, that is what is the whole purpose of performing a fast. How do you perform it? We saw that we are keeping the probe at 4 positions: epigastric, right hypochondrium, left hypochondrium, and the pelvic. And it is basically done in the emergency room. It is nothing. It is basically a USD, which is done in the emergency room. And yeah, that's it. That's pretty much it. Okay, right? Okay. Now, what you need to understand over here, when you perform a fast, you cannot comment whether the patient is having a hemothorax or a hydrothorax or something like that. You don't. Okay. So what you need to understand over here, okay, if at all you want to check for the hemothorax and the hydrothorax and all those stuff, you have to perform something which is called as an e-fast. What is e-fast? It is called as an extended fast. Now, what is this extended fast? Here, you keep your USG probe in the right and the left thoracic region as well. Okay, that is where you keep it. Now, in this, you have two signs. One is basically called as a seashore sign, and another one is basically a barcode sign. So, what is the seashore sign? Seashore sign basically tells you that, you know what, lungs are expanding, they're coming and they're hitting the thoracic cavity and then they're going back. So this is what is referred to as a seashore sign. It is normal finding. It is present in you and me both. Okay, so it is basically present in all of us. Then we have a barcode sign. What is this barcode sign? If at all, let's say there is a hydrothorax, let's say there is an air which is basically present between the lung and the thoracic cavity. When you perform a USG, what is going to happen? This air, it acts like an artifact. Okay, air basically acts like an artifact, and because it is acting like an artifact, it will give you a barcode sign. It is also referred to as a stratosphere sign. So barcode sign and a stratosphere sign are one and the same thing. They are basically present in the pneumothorax, and in the normal individuals, what do we get? We basically get a seashore sign. That is a normal finding. This is a USG which was shown in your once in AIIMS. It is basically telling you that, you know what, there is a normal kind of seashore sign present in the normal individual. And here, as you are able to appreciate, all of this is an artifact. And this is what is trying to tell you that this is like a barcode, and this is what is a barcode sign. Okay, I hope you are able to understand this point. The next thing which we want to understand is DPL. What is this DPL? It is called as a diagnostic peritoneal lavage. Now, what is this diagnostic peritoneal lavage? Again, what is the reason? Why do you want to perform it? So the reason why we want to perform a diagnostic peritoneal lavage is again for the same damn thing. We want to look for an intraperitoneal fluid collection. Peritoneal fluid. Now, around, let's say 30, 40, 50 years back, we did not have that USG, right? So we couldn't perform the fast. But still, the surgeons at that time, they had a dilemma that whether there is any intraperitoneal fluid collection or not. And in that particular scenario, they used to perform a diagnostic peritoneal lavage. How do you perform it? You put an incision in the infraumbilical region, you cut the peritoneum, you enter into the abdominal cavity. Once you are into the abdominal cavity, you direct the tip of this particular catheter. So you use a hard catheter or the stiff catheter over here. You direct that particular tip of that particular stiff catheter towards the pelvic cavity. Okay, you direct it towards the pelvic cavity, you take a 10 cc syringe and you try to aspirate. If on the aspiration you get more than 10 ml of the frank blood, okay, if you get more than 10 ml of the frank blood, it is a diagnosis. It is called as a positive diagnostic peritoneal aspirate. Okay, it is called as a positive diagnostic peritoneal aspirate. Am I making some sense over here? What do? You basically enter into the peritoneal cavity, you go to the pelvic cavity, and then what you do, you aspirate. If you get more than 10 ml of the frank blood, this is what is called as a diagnostic peritoneal, positive diagnostic peritoneal aspirate. But if at all you don't get this, what you do, you attach a kind of a 1 liter of the fluid, you let it flow inside the peritoneal cavity, you let it stay there, the fluid. When you re-aspirate the fluid, what you do, you send it for the microscopic examination. I hope it makes sense. 1 liter of the fluid allowed to stay there for half an hour. You re-aspirate it. Once you re-aspirate it, you send it for the microscopic examination. Now, in the microscopic examination, if you get that the RBC count is more than 10 to the power 5, okay, RBC count is more than 10 to the power 5 per ml, and the WBC count is more than 500. Okay, if the WBC count is more than 500 or the RBC count is more than 10 to the power 5, this is what you call as a positive diagnostic peritoneal lavage. Okay, this is all you need to remember and understand regarding the fast and the diagnostic peritoneal lavage. Okay, so we have got done with the two basic terminologies. Now let us talk in detail about the management protocol for the blunt abdominal trauma. Now this is very, very important. Let's say you go to a casualty and there is a patient with a blunt abdominal trauma. What is the first thing you want to look for? You want to look for the hemodynamic stability of this particular patient. Now, how can we determine the hemodynamic stability? For determining the hemodynamic stability, you have to assess the blood pressure of this particular patient. If at all the blood pressure is more than 90 millimeters of mercury, you say that this particular patient is hemodynamically stable. But if at all the blood pressure is less than 90 millimeters of mercury, you say that, you know what, this particular patient is hemodynamically unstable. Are you able to understand this point? So you assess the hemodynamic stability by looking at the blood pressure. If at all the blood pressure is more than 90 millimeters of mercury, the patient is hemodynamically stable. If at all the blood pressure is less than 90 millimeters of mercury, the patient is hemodynamically unstable. Now let us talk about if at all the patient is hemodynamically unstable. What is the first step you need to do? You need to go in for a fast. Okay, if at all the patient is hemodynamically unstable, you need to go in for a fast. If at all the fast is positive, okay, if at all the fast is positive, you go ahead and do a exploratory laparotomy. You straight away go in for an exploratory laparotomy. But if at all, let's say the fast is equivocal. What do you mean by equivocal? That the radiologist is not able to tell with certainty that whether intraperitoneal fluid is present or not. He's not able to tell with certainty. So how this is like, if at all, let's say the patient is very, very obese, or let's say the patient is patient is very, very obese or something like that, or let's say the USG probe is not in a good condition, you will not be able to tell whether this particular patient is having an intraperitoneal fluid collection or not. In this particular scenario, what you need to do, you have to perform a diagnostic peritonial lavage. If at all you perform a diagnostic peritonial lavage and if it comes out to be positive, you straight away go in for an exploratory laparotomy. Are you able to understand this point? So yeah, this is the management protocol for the blunt abdominal trauma. Okay, if at all the patient is hemodynamically unstable. On the other hand, let's talk about if at all the patient is hemodynamically stable. Now, please pay attention. What is the first thing? You have to look for signs of peritonitis. What do you understand by signs of peritonitis? So you have to look for whether there is any localized guarding, whether there is any localized rigidity or something like that. Okay. So guarding or rigidity, these are the two main important signs of your peritonitis. If at all the signs of peritonitis are present, you straight away go in for an exploratory laparotomy. You don't need any other investigation. Are you able to understand this point? So if at all the signs of peritonitis are present, do you need any investigation? No, not at all. Straight away go in for an exploratory laparotomy. But if at all the patient is not having the signs of peritonitis, then you perform the CCT, then you perform the fast, and based on whatever the findings you get from the CCT and the fast, you decide whether you want to manage this particular patient conservatively or do you want to go in for an exploratory laparotomy. I hope it makes sense, guys. I hope it makes sense. So this is all about the management protocol for the blunt abdominal trauma. And finally, there are the 4 one-liners which are asked on this particular concept. Okay, so before going through this, I'll just quickly revise your management protocol for the blunt abdominal trauma. What is the first thing you do? So you check for the hemodynamic stability. If at all the patient is hemodynamically unstable, in other words, the systolic blood pressure of this particular patient is less than 90 millimeters of mercury. If at all this is a condition, then what you do, you perform a fast. If at all the fast is positive, you straight away go in for an exploratory laparotomy. But if at all, let's say the fast is equivocal, you go ahead and do a diagnostic peritonial lavage. If at all that is positive, you go ahead and do an exploratory laparotomy. But let's say if at all the kind of a fast, if at all the patient is hemodynamically stable, you check for the signs of peritonitis. If the signs of peritonitis, that is rigidity and the guarding, if at all they are present, no other investigation needed, straight away going for an exploratory laparotomy. But if at all the signs of peritonitis are absent, then you can go perform a CCT and the fast, and based on the based on that, you can decide whether you have to go in for a conservative management or an exploratory laparotomy or something like that. Now, these are the 4 one-liners which they basically ask you. They ask you what is the first investigation. They ask you what is an investigation of choice. So if at all they give you a patient of a blunt abdominal trauma who is hemodynamically stable, what is the first investigation? The first investigation is the fast. But what is the first investigation in the hemodynamically unstable person? There also it is the fast. So stable, unstable, the first investigation is always a fast. But if you talk about the hemodynamically unstable person, if they ask you investigation of choice, it is still the fast. Because if you look at the protocol, based on the fast, you were taking a decision whether you want to go in for an exploratory laparotomy or not. On the other hand, if at all there is a hemodynamically stable person, then the investigation of choice will become contrast enhanced CT scan. Okay, I hope it makes sense to you guys. Now let us go back to the question which we were talking about. The question which we were talking about was, there is a patient who came to the hospital, vitals are more or less stable, BP is 110 millimeters of mercury, systolic blood pressure, pulse rate is 90 per minute. Abdominal examinations show signs of peritonitis. What is the next step? You have to go in for an exploratory laparotomy. Why? Because the peritonitis signs are present. Okay, so that's why the answer over here is B. Okay, so I hope you understood this particular concept. This is a pretty simple management protocol for your blunt abdominal trauma. Thank you for listening to this particular thing so patiently, and yep, I hope you gain something out of it. As you know, I'm also an educator on your Unacademy platform, and yeah, we have a lot of exciting things happening over there. So we have your Plus subscription where you'll find a lot of structured and detailed courses for your upcoming exams, and then there is also a lot of free classes which are going on. So this is basically the YouTube thing which we are doing, but at the same time, you can download our app and you can look at, browse through all the important things which are present on this particular platform, right? You can attend the free special classes and all. At the same time, we are coming up with a championship T20 test, which is to be conducted very, very soon on 15th of November, morning 10 a.m. You can kind of go and attend it. It is a kind of a nationwide free grant test which we are conducting, which will be a very, very close replica of your upcoming NEET PG exam. And at the same time, if you are interested in taking a combined subscription of an academy along with the prep ladder, that is again possible. That is what is we call it as an iconic subscription. You can definitely kind of avail that also if at all you are interested into it. Thank you so much, guys. Thank you for joining with me. Have a great day. Happy studying. And if you want to take any of these particular subscriptions, you can consider using my promo code, that is Surgery 101. And yep, thank you so much. Have a great time. Happy studying. See you. Bye bye.